Hello everyone. Today is day 20 of discussing important perio tables from Dental Pulse. Today we will discuss phases of periodontal therapy. Periodontal therapy is not done randomly. It is a treatment that is carried out in systemic phases. Each phase has a specific goal and one phase prepares the foundation for the next. So, before starting definitive periodontal treatment, we first manage emergencies and urgent conditions. This is called the preliminary phase. This phase mainly includes the treatment of emergencies, which may be dental emergencies like acute pulpitis, periapical emergencies like abscess, periodontal emergencies like periodontal abscess or ANAG, and other emergencies such as trauma or swelling. Another important component is the extraction of hopeless teeth. Teeth with severe bone loss, grade 3 mobility, poor crown to root ratio, or unfavorable prognosis are removed to eliminate infection and improve overall treatment outcome. So, if required, provisional replacement may be given for aesthetics or function, but it can be postponed until inflammation is controlled. So that then the next phase is phase 1, non-surgical phase or atiotropic phase. This is the most important phase of periodontal therapy because it addresses the cause of the disease. The primary goal of the phase 1 therapy is to eliminate plaque, calculus and all local irritational factors. First is plaque control in patient education. Patients are educated about proper brushing techniques, interdental cleaning aids, and the importance of oral hygiene maintenance. Because plaque is the primary etiologic factor, patient motivation is crucial. Then comes the scaling and root planing. This involves removal of supragingival and subgingival calculus, plaque biofilm, and contaminated cementum. The objective is to produce a smooth root surface that allows gingival healing and reattachment. Now next is the correction of local factors. All plaque retentive factors such as overhanging restorations, faulty crowns, ill-fitting prosthesis are corrected during this phase. Next is caries control and restorations. Caries are excavated and restored using temporary restorations or permanent restorations depending on prognosis. This will help eliminate additional plaque retentive sites. Next is antimicrobial therapy. In selected cases, antimicrobial therapy may be used, like with local delivery systems or systemic antibiotics. This is only an adjunct and not a substitute for mechanical therapy. Next comes the occlusal therapy. Occlusal adjustment is done to manage trauma from occlusion, which may otherwise worsen periodontal destruction. Next is minor orthodontic movement and splinting. Minor orthodontic movements may be done to improve plaque control and tooth positioning. Provisional splinting may be used to stabilize mobile teeth and improve patient comfort. Next is the re-evaluation phase. After completion of phase 1 therapy, re-evaluation is mandatory. At this stage, we assess pocket depth, gingival inflammation, bleeding on probing, plaque and calculus levels, and caries status. Based on the tissue response, we decide whether surgical intervention is required. Then comes the stage 2 or phase 2 is surgical phase. This phase is indicated when deep pockets persist, bone defects remain, or inflammation does not resolve after phase 1 therapy. Surgical procedures may include flap surgery, osseous surgery, regenerative procedures, periodontal plastic surgery, and implant placement when indicated. Then is the phase 3 or the restorative phase. Once the periodontal health is stabilized, we move to the restorative phase. This phase focuses on restoring the function, aesthetics, and occlusal harmony. It includes final restorations, crowns and bridges, fixed or removable prosthesis, and endodontic therapy if required. Periodontal stability is essential before final restorations. Then comes the phase 4 or the maintenance phase, also known as supportive periodontal therapy. This is a lifelong phase of periodontal care. The aim is to prevent recurrence of disease and maintain treatment results. So maintenance includes periodic recall visits for plaque and calculus removal, evaluation of gingival condition, monitoring pocket depth and attachment levels, reinforcement of oral hygiene instructions. So, according to Linde, maintenance therapy is critical for long term success of periodontal treatment. To summarize, periodontal therapy follows a logical sequence. Preliminary phase, phase 1 is the etiologic therapy, then comes the re-evaluation phase, then comes phase 2 or the surgical therapy, then comes phase 3 that is the restorative therapy, then comes phase 4 that is the maintenance therapy. Each phase is essential and cannot be skipped if long-term periodontal health is to be achieved. Thank you.